Patient's here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in absolute
Your left
hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. Today we are wading into waters that I think a lot of nursing students, and honestly plenty of seasoned educators, find pretty intimidating.
Yeah.
We are tackling pediatric hematology and oncology. It's a unit that, it usually comes with a heavy emotional tax, but also just a massive cognitive load because the physiology is so specific.
It is a massive topic. It really is. It's one of those units where the textbook feels like it weighs 50 pounds, and then the emotional weight of the content is even heavier.
Right.
But we aren't here to memorize every single cytogenetic subtype of leukemia. We are here to figure out what actually matters when you're standing at the bedside or, sitting in that exam room.
Exactly.
We need to strip away the noise and just find the signal.
And looking at our source stack for today, we have got some serious material to work with.
We do.
We've got a comprehensive pediatric hematology oncology textbook chapter that goes incredibly deep into the pathophysiology, the real nitty-gritty of cellular development. Then we have a rapid review exam prep guide, which is, essentially the high-yield cheat sheet for the boards.
The Cliff Notes version.
Yeah, exactly. And then we have these very, very dense drug monographs for methotrexate and prednisone,
which are two of the absolute cornerstones of treatment in this world. If you don't understand those two drugs, you just don't understand pediatric oncology.
Everywhere.
They appear in almost every single protocol.
So here is the mission for this deep dive. We know our listeners are out there preparing students for high-stakes exams, or maybe you are a nurse looking to sharpen your clinical eye.
Right.
We want to take these, thousands of pages and cross-reference them into what we're calling a Pareto 80-20 map.
I love that framework.
We want to find the 20% of the hematologic concepts that generate 80% of the exam questions, and critically, 80% of the safety saves at the bedside.
And we're going to filter all of that through two specific lenses. The first lens is safety and exam priority, basically. What kills the patient?
And what fails the student?
Exactly, what fails the student. But the second lens is the one that really makes pediatrics unique, and that's development.
Because you aren't just treating a small adult. That's the cardinal rule of PEDs, right?
Right there. Never, ever. You are treating a developing human. So you have to ask yourself, how does this disease or this life-saving treatment, how does it mess with their timeline? How does it affect their ability to walk, to learn, to hit puberty, to just be a kid? That tension between saving the life and preserving the childhood, that's where the real deep dive happens.
It's so important.
It's not enough to cure the cancer if we, destroy the child's development in the process.
I love that framework. So let's zoom out before we get into the weeds of sickle cell or leukemia. When you look at this master 80-20 map of the source material, is there a unifying pattern?
There is. There really is. If you are taking notes, draw a big triangle.
Yeah.
The overarching theme here is bone marrow failure. Almost every condition we're going to discuss today eventually leads back to the factory, the bone marrow, either shutting down or just malfunctioning completely.
And that creates a specific set of symptoms.
A very specific triad of symptoms that I have to say exam writers absolutely love to test.
This is what we call the heme-onc red flag pattern.
It is, and you have to know this triad cold. The first point of the triangle is anemia. The factory just isn't making red blood cells. So clinically, what do you see?
You see pallor.
You see pallor. They look like porcelain or wax sometimes. You see extreme lethargy. The kid who used to run around all day is now napping 3 times a day.
Right.
And physiologically, you see tachycardia. The heart is just racing to pump what little oxygen it has to the vital organs.
Okay, so that's point 1 of the triangle. What's the second point?
Thrombocytopenia. So the factory isn't making platelets. These are your plugs, right? So you see bruising from minor bumps. We call it easy bruising. You see bleeding gums when they brush their teeth.
And those little red dots.
Petechia, yes. Those tiny, non-blanching red dots that look like a rash but are actually broken capillaries under the skin. A huge red flag.
And the third point of the triangle.
Neutropenia. The factory isn't making functional white blood cells. Or, in the case of leukemia, it's making billions of them. But they're useless, immature weeds.
So they're not actually fighting infection.
Not at all. So the patient presents with fever, or, specifically in leukemia, deep bone pain. Because the marrow is so packed with these bad cells, it's literally expanding inside the bone shaft.
Wow. So if a student sees a test question description of a child who is pale, bruised, and complains of leg pain, that is not growing pains.
That is a 5-alarm fire. That is the bone marrow failure triad just screaming at you. You need to be thinking malignancy or plastic anemia immediately.
Okay.
You cannot dismiss those 3 symptoms when they appear together.
So within this map, we also identified 3 can't-miss safety items. These are the things that are, instant failures if you miss them on an exam, or catastrophic outcomes in real life.
Yes.
Walk us through the top one.
Sepsis in sickle cell disease. We will unpack the why a little later, but the headline is this. Fever in a sickle cell patient is a medical emergency.
An emergency, not just something to watch.
It is not a give them Tylenol and wait situation. Their spleen, which is our main filter for bacteria, it functionally dies very early in the disease. So they can go from a fever of 101 to dead from sepsis in a matter of hours.
That's terrifying, but such a crucial distinction. It changes the triage priority completely.
Completely.
What's the second one?
Head trauma and hemophilia. If a hemophiliac child bumps their head, you treat first, scan second.
Say that again. Treat first, scan second.
You administer the clotting factor immediately. Do not wait for the CT scan cue. By the time you see the bleed on the image, the brain damage might already be done. Time is tissue.
Oh, got it. And the third can't miss item ties back to that neutropenia piece we mentioned in the triad.
It does. It's the calculation of the ANC, the absolute neutrophil count. If that number is low, usually under 1,000 or even 500, depending on the protocol, the rules of engagement change completely.
And the big rule is no rectal temperatures.
No rectal temperatures.
Why is that such a hard and fast rule? I know it sounds like a basic nursing school thing, but what's the mechanism?
It's because the rectal mucosa is so fragile. If you insert a thermometer and cause a micro tear, even one you can't see, you have just introduced gut bacteria directly into the bloodstream of a child who has zero immune system to fight it.
Wow. It's a direct line to
It's
septum.
a direct line. It's the same reason we say no fresh flowers. They carry fungal spores like aspergillus. And if they spike a fever, you start broad-spectrum antibiotics immediately. You don't pass go. You don't wait for cultures. You act.
That sets the stage perfectly. We have our safety landscape.
Now, let's move into the specific disease process lecture. We've synthesized the sources into 4 main conditions: iron deficiency anemia, sickle cell, hemophilia, and leukemia.
Right.
Let's start with the most common one globally: iron deficiency anemia, or IDEA.
Often referred to as the milk anemia.
Which sounds so deceptively harmless. It does, but it's a massive developmental thief. Let's strip it down to the plain language patho. Think of iron as the brick.
Okay.
You need bricks to build a house. In this case, the house is hemoglobin, which is the truck that carries oxygen.
Right.
If you have no bricks, you build fewer trucks. And the trucks you do build are small. We call that microcytic, and pale, we call that hypochromic.
So you have this fleet of tiny, empty trucks trying to supply oxygen to a whole growing body.
Precisely. And the body compensates by running the engines harder. That's why you get tachycardia. The heart is beating faster to cycle those few trucks around as many times as possible. But eventually, the engine just can't keep up.
Now, the milk baby presentation is something that often trips people up on exams and in the clinic, because we usually associate malnutrition with being, skinny or wasted.
Right. But the classic milk baby is a toddler, usually between 12 and 24 months, who is chubby. They look well-fed, maybe even overweight.
But they're pale.
But they are pale, almost waxy, and they are so lethargic.
So what's the mechanism there? Why are they chubby if they're actually malnourished?
They are filling up on cow's milk. Some of these kids drink 30, 40 ounces a day. And cow's milk is high in calories, hence the weight gain, but it has effectively 0 iron.
So it's empty calories, in a way.
Totally. It displaces solid foods that contain iron. And even worse, in young toddlers, the cow's milk protein can irritate the lining of the gut, causing microscopic bleeding, so they aren't consuming iron and they are losing blood in their stool.
It's a double whammy of deficiency.
It is a complete double whammy.
Then you have the other peak age group, the adolescents. It presents differently there, doesn't it?
Different mechanism, same result. You have a teenager hitting a massive growth spurt, so there's a high demand for bricks to build muscle and blood volume.
Right.
They have a poor diet, likely high in junk food and low in leafy greens. And for females, they start menstruation, so they are losing blood monthly.
And this kid presents differently.
Very differently. It's the student falling asleep in class, the lazy teenager who is actually hypoxic, or the athlete who suddenly can't keep up with the team. It's fatigue and poor concentration.
Let's hit the need-to-know data points for the exam. What are the top expected findings you're looking for?
Tachycardia is a big one. Pallor, but you have to know where to look. Don't just look at the face, especially in darker-skinned children.
Where do you look?
You look at the conjunctiva of the eyes and the palms of the hands, and often a systolic heart murmur.
And what causes the murmur?
That's simply the physics of thinner, less viscous blood rushing through the valves. It's turbulent, and that turbulence makes noise. It's not a structural heart problem, it's a flow problem.
And the labs? What are the key indicators?
Low hemoglobin, low hematocrit, that's a given. But then low MCV, that's the microcytic or small cell size, and low ferritin.
What's ferritin again?
Ferritin is your iron storage protein. It's the bricks in the warehouse. That's actually the first thing to drop even before the hemoglobin itself starts to fall.
Now, interventions. Iron supplementation seems simple, but the pharmacology has some really specific traps that examiners love.
Oh, they love them. The biggest trap involves absorption. Iron is finicky. It needs an acidic environment to be absorbed effectively in the duodenum.
So you give it with something acidic.
Exactly. The golden rule is give it with vitamin C, orange juice, tomato juice, or just a citrus fruit. It boosts absorption significantly.
And the inverse, what kills the absorption?
Calcium. Calcium neutralizes the acid. So the exam trap is the parent who says, oh, I mixed the iron drops in his morning bottle of milk, so he takes it.
You have to stop that.
You have to stop that immediately. They are completely neutralizing the medication. So no milk, no antacids within at least an hour of taking the iron.
What about the side effects? This is where patient adherence usually fails because, let's be honest, iron is rough on the stomach.
It is. It causes constipation, so we need to push fluids and fiber. But the scary one for parents is the stool color. Iron turns the stool a tarry, dark green, or black. If you don't warn them, they will think it's a GI bleed and rush to the ER.
Every time.
You have to normalize that. You say, your child's poop will turn black. That means the medicine is working. If it doesn't turn black, they probably aren't taking it.
And what about the teeth staining? That's a real issue.
It is a real issue with liquid iron for toddlers. It stains their teeth black, so you teach them to use a straw or a dropper placed at the back of the throat to bypass the teeth and then brush immediately after. It's temporary, but it looks very alarming.
Let's apply that developmental lens we talked about. Why is ID such a big deal for a toddler? I mean, why not just wait until they eat better?
This is the part that I think keeps me up at night. Iron isn't just for hemoglobin. It is a necessary cofactor for neurotransmitter synthesis in the brain.
Oh, wow.
Chronic hypoxia and iron deficiency in infancy causes long-term, sometimes irreversible cognitive deficits. We're talking about lower IQ scores, behavioral issues, and learning disabilities that persist even after you fix the anemia.
So you're not just fixing a lab value.
You're not just fixing lab value. You are protecting the entire architecture of their developing brain. It's that serious.
That is a powerful why. One more quick, nice to know before we switch diseases.
Lead poisoning.
Ah, yes.
Peeking out the craving to eat non-food items like dirt or paint chips is really common in iron deficiency. The body is just screaming for minerals.
And if they eat old paint chips?
They get lead poisoning. And lead actually displaces iron in the hemoglobin molecule. So if you see a kid with anemia, you should always screen for lead and vice versa. They are absolute partners in crime.
Okay, that's great. Moving on to the heavyweight champion of pediatric hematology, sickle cell disease.
A traffic jam disorder.
I love that visual. The pictorial here is fascinating, but it's pretty complex. Walk us through the shape-shifting.
So normal red blood cells are these round, squishy donuts. They can slide through tiny capillaries, single file, no problem. In sickle cell, the child has a genetic mutation where they produce hemoglobin S instead of the normal hemoglobin A. And when these cells get stressed by dehydration, cold, infection, or low oxygen, they polymerize.
And what does that mean?
It means they turn into rigid, sticky crescent moons.
Or sickles. And square pegs don't fit in round holes.
Exactly. They hook together and create a physical blockage in the blood vessel. That's a vaso-occlusive crisis.
The traffic jam.
The traffic jam. Blood can't get past it, so the tissue downstream gets no oxygen. And ischemia equals pain. Severe screaming pain.
Now, age presentation. A newborn with sickle cell usually looks perfectly healthy. Why is that?
Fetal hemoglobin, or HbF, we all have it in the womb. HbF is a superstar. It holds oxygen very tightly, and it absolutely refuses to sickle.
So it's protective.
It's totally protective for the baby for the first 3 to 4 months of life. But as it naturally fades and the adult HgbS takes over, that's when the symptoms start.
And the first sign is usually dactylitis.
Yes, hand-foot syndrome. The tiny vessels in the fingers and toes are the first to get clogged, so the hands and feet swell up like sausages and are incredibly painful. If you see a 6-month-old crying with swollen hands, that is sickle cell until proven otherwise.
Let's talk about the complications, because this is where all the safety questions come from. We already mentioned sepsis and asplenia.
Right. So the spleen gets clogged so many times by these sickled cells that it infarcts and basically shrivels up and dies. By age 5, most of these kids are functionally asplenic.
Which means they can't filter bacteria.
They can't filter encapsulated bacteria like pneumococcus. That's why they are on prophylactic penicillin every single day to act as a kind of chemical shield.
What about acute chest syndrome? I see this term in every textbook, and it's always highlighted.
It should be. This is the leading cause of death in adolescents and adults with SCD. It looks like pneumonia fever, cough, chest pain, a new infiltrate on X-ray. But what's happening is sickling in the lung vasculature.
And that creates a feedback loop, right?
It's a vicious cycle. The pain makes them breathe shallowly. We call that splinting, which causes hypoxia, which causes more sickling in the lungs, which causes more pain. You have to intervene fast with oxygen and fluids, or it just spirals into respiratory failure.
And splenic sequestration. This is different from the shriveled spleen, right?
Completely opposite. Usually this happens in younger kids whose spleen is still working a bit. The spleen suddenly acts like a giant sponge. It just sucks a massive amount of blood volume out of circulation and traps it.
So the spleen gets huge.
The spleen becomes huge. You can feel it filling the belly, and the child goes into hypovolemic shock because there is literally no blood left in circulation. This is an immediate life threat requiring volume replacement and blood transfusion to push the blood back out.
Okay, let's get to the interventions. The mnemonic is HOP.
HOP to it. H is for hydration. This is your #1 tool. You need to dilute the blood to break up the traffic jam and lower the viscosity. We run IV fluids at 1.5 to 2 times the maintenance rate. We want them well watered.
Okay, H is hydration. O.
O is for oxygen. But there's a caveat here. Only if they are hypoxic. Giving oxygen won't unsickle the cells if their saturation is already 99%. But we absolutely need to prevent hypoxia to stop new sickling from happening.
And P is for?
P is for pain management.
And this is where we really need to have a serious culture conversation regarding nursing bias.
We absolutely do. The pain of a vaso-occlusive crisis is often compared to bone fracture pain or a heart attack. It is ischemia. It is tissue death.
So we treat it seriously.
We treat this with opioids, morphine diluted, and we give it around the clock, ATC, or via a PCA pump. We do not give it PRN as needed.
Why not PRN?
If you wait for the child to be crying in agony before you give the next dose, you are chasing the pain and you will never, ever catch it. And please check your bias. These children are not drug-seeking addicts. They are seeking relief from dying tissue.
Is there a specific medication contraindication here, an exam favorite?
Meperidine, or Demerol. Never use it. It breaks down into a metabolite called normeperidine, which accumulates and lowers the seizure threshold.
And these kids are already at risk for stroke.
Exactly. Sickle cell kids are already at high risk for strokes and CNS changes. Giving them a drug that can cause seizures is just malpractice. Do not choose Demerol on the exam.
What about temperature management? You're managing pain, you're managing hydration.
Good question. Heat is good. It vasodilates. Cold is bad. It vasoconstricts. Never, ever put an ice pack on a sickle cell pain crisis. You will tighten the vessels and make the traffic jam 100 times worse.
Looking at the developmental impact, this is a chronic, lifelong battle. It has to take a toll.
It does, a huge toll. Growth retardation is common because their metabolic rate is so high. The body is working overtime just to make blood and fight infection. They are often smaller than their peers and hit puberty later.
And that's tough socially.
It's so tough socially for a 14-year-old who looks 10.
And school.
They miss a lot of school due to pain crises. But the shadow that's always looming over them is stroke. About 11% of untreated kids will have a stroke by age 20. Even silent strokes can cause cognitive decline. That's why we do transcranial Doppler screenings annually from age 2 to 16. We are looking for high-velocity blood flow in the brain, which implies the vessels are narrowing.
One nice-to-know therapy before we move on.
Hydroxyurea. It's a chemotherapy agent, technically, but at lower doses, it stresses the marrow just enough to trick it into making fetal hemoglobin again.
And we know HbF is protective.
Exactly. Remember, HbF doesn't sickle. It's the only drug we have that actually modifies the course of the disease. It's a game changer.
Incredible. Okay, let's shift gears to number 3, hemophilia.
The missing glue.
So in this case, the platelets, the initial plug, they work just fine.
Correct. You get a cut, platelets rush in, they form a plug, the bleeding stops initially, but to keep that plug there, you need the fibrin mesh, the clot. That comes from the clotting cascade.
And in hemophilia,
One of the dominors in that cascade is missing, so the plug eventually washes away and the bleeding restarts.
can you distinguish hemophilia A versus B for us?
Hemophilia A is missing factor VIII. I always say A, it sounds similar, helps to remember. That's the most common, about 80% of cases. Hemophilia B is missing factor IX, also called Christmas disease,
And this is X-linked recessive.
which means mom is the carrier and the son gets the disease. It is overwhelmingly a male diagnosis.
When do we usually spot this? At birth.
Often at circumcision, that's a big one. Prolonged bleeding. If not, then it's when they become mobile. The toddler phase is so dangerous. They fall, they bump their heads. A normal kid gets a bump. A hemophiliac gets a massive hematoma. Or a frenulum tear in the mouth that just won't stop bleeding because saliva breaks down clots naturally.
Let's look at the need-to-know exam profile for hemophilia.
Easy bruising, obviously. But the hallmark is hemarthrosis bleeding into the joint spaces. Knees, ankles, elbows.
What does that look like?
The joint fills with blood, it becomes hot, swollen, incredibly painful, and locked in place. And over time, that iron in the blood actually destroys the cartilage and causes permanent deformity.
And the labs. This is a classic question, differentiating bleeding disorders.
It is. You have to know the difference between platelets and factors. In hemophilia, the platelet count is normal, the PT is normal, the PTT partial thromboplastin time is prolonged.
Why the PTT?
Because PTT measures the intrinsic pathway, which is where factors 8 and 9 live, so that's the one that will be abnormal.
Interventions. We talked about treat first for head trauma. That's paramount.
Vital. Factor replacement is the priority. If a hemophiliac falls off a swing and hits their head, you push factor VIII or ISAKI immediately. You don't wait for symptoms, you don't wait for the scan, you push the factor.
What about for the joint bleeds? Is it rice?
Yes. Rest, ice, compression, elevation. Here, ice is your friend because the vasoconstriction slows the bleeding into the joint. But again, rice is secondary to factor replacement. You have to give the glue first.
Now let's talk about pain meds. We said opioids for sickle cell. What about for hemophilia?
This is a really tricky one and a huge safety point. No NSAIDs, no aspirin, no ibuprofen, no naproxen.
And why is that?
Because NSAIDs inhibit platelet aggregation. These kids already have a broken clotting cascade. If you knock out their platelets too, they have literally zero defense. They will bleed uncontrollably.
So Tylenol, acetaminophen is the king here.
Correct. Unless the hematologist specifically clears a certain NSAID regimen for joint inflammation, you stick to Tylenol and opioids if needed for severe pain.
The developmental impact here really changes how they play, doesn't it?
It does. Contact sports are completely out. No football, no rugby, no wrestling, no hockey. One hard tackle could cause a life-threatening bleed. And that's really hard for a boy who wants to fit in with his friends.
So what do we encourage?
Non-contact sports. Swimming is the absolute best. It builds muscle to support the joints without any impact. Golf, fishing, cycling with a helmet and pads, things like that.
And what about autonomy?
This is one of the great success stories of modern nursing. We teach these kids to self-administer their 5e factor prophylactic infusions at home. By age 8 to 12, many of these boys are mixing their own factor and sticking their own veins.
That's incredible.
It gives them control over a disease that threatens to control them. It's really empowering.
A quick nice to know before we move on.
DDAVP, or desmopressin, it's a synthetic hormone. For mild hemophilia A, it stimulates the body to release stored factor VIII from the blood vessel walls.
So it can stop a minor bleed.
It can, without a transfusion, but it does not work for hemophilia B because they don't have a factor VIII issue, or for severe hemophilia A because they have no stores of factor VIII to squeeze out.
Got it. Okay, fourth and final disease, leukemia. Specifically, all acute lymphoblastic leukemia.
Weeds in the garden.
Break that down for us.
The bone marrow is a garden. It's meant to grow flowers, which are your red blood cells, vegetables, your white blood cells, and fruits, your platelets.
Yeah.
In leukemia, a single immature cell, a blast, mutates. It's a weed. It replicates incredibly fast. It doesn't do any work. It just takes up space. And eventually, the garden is nothing but weeds. The good plants are crowded out, and they die.
So the patient has these super high counts of blast cells, but they're still immunocompromised.
Exactly. A child might have a WBC count of 50,000. Normal is maybe 10K, but they're all useless blasts. They don't fight infection. So the child is functionally neutropenic, even with a high white count.
Who gets this? What's the typical age?
Peak onset is 2 to 5 years old. It's really a preschool disease.
And the presentation ties right back to our initial triad.
It does. Anemia, so they're tired. Thrombocytopenia, so they're bruising. Neutropenia, so they have a fever. But for leukemia, you really need to watch for bone pain and a limp.
The expanding marrow.
The marrow is expanding from the pressure of the tumor burden inside the bone. If a toddler suddenly refuses to walk, you check a CBC.
Diagnostics. How do you confirm it?
A peripheral smear will show the blasts, but the definitive diagnosis is the bone marrow biopsy. You need to see greater than 25% blast cells in the marrow to confirm leukemia.
And why do we do a lumbar puncture?
Leukemia cells are smart. They like to hide in what we call sanctuary sites where 5e chemo can't reach them easily. The central nervous system is one of them because of the blood-brain barrier.
So you check the spinal fluid.
We check the spinal fluid. If there are cells there, or even if there aren't as prophylaxis, we have to inject chemo directly into the spine. We call that intrathecal chemotherapy.
Let's talk about a major safety emergency during treatment. Tumor lysis syndrome.
This happens usually during induction. That's the first phase of chemo where we just blast the cancer. We kill millions of cells instantly, and they burst open, they lyse.
And cells are just bags of chemicals.
Right. They are full of potassium and uric acid. When they burst, they dump all of that into the bloodstream all at once.
And that causes two huge problems.
Two huge problems. First, you get hyperkalemia. High potassium leads to fatal cardiac arrhythmias. Second, you get hyperuricemia. Uric acid crystals form in the kidneys and cause acute renal failure.
So how do nurses prevent this from becoming a catastrophe?
Hydration, hydration, hydration. We flush the kidneys like a fire hose to keep those crystals from forming. And we give a drug called allopurinol, which stops uric acid production in the first place.
The developmental impact here is so visibly profound.
It's heartbreaking. You have a 4-year-old, they lose their hair, alopecia, they get a moon face from the high-dose steroids. They look different. And because of the neutropenia, they are isolated.
They can't go to preschool.
They can't go to preschool. They can't see friends. You often see regression potty-trained kids go back to diapers or they start baby talking again. It's a totally normal response to trauma and isolation.
One safety, nice to know, regarding vaccines. This seems critical.
Absolutely critical. No live vaccines while on chemo, no MMR, no varicella for chickenpox, no nasal flu mist. Their immune system cannot handle the live virus. It can cause the actual disease. We have to rely on herd immunity to protect these kids.
That covers the diseases. Now, let's pivot to the how, the medication module. We are focusing on 2 drugs that appeared in every protocol we reviewed, methotrexate and prednisone.
Let's start with methotrexate.
This is a chemo drug, but it's also used for juvenile rheumatoid arthritis. How does it work?
It's an antimetabolite, specifically a folate antagonist. It's a master of disguise.
Of disguise.
It looks chemically just like folic acid. The cancer cell, which is hungry and dividing really fast, grabs the methotrexate thinking it's food, thinking it's folate to build DNA. But it's a trap. It blocks DNA synthesis and the cell starves and dies.
But it affects healthy, rapidly dividing cells too.
It does. Any rapidly dividing cell. That includes the bone marrow, which is why you get myelosuppression, and the lining of the GI tract, which is why you get mucositis.
There's a specific rescue associated with high-dose methotrexate that we have to talk about.
Leucovorin rescue. Leucovorin is a form of folic acid that actually bypasses the metabolic block from the methotrexate. It effectively rescues the healthy cells from the toxic effects of the drug.
And the timing is critical.
The timing is everything. In high-dose protocols, if you miss the leucovorin dose or give it late, the patient can suffer fatal toxicity. It's a huge med safety issue.
And we also have to watch the urine.
Yes. Methotrexate precipitates, it crystallizes in acidic urine. It will destroy the kidneys. So we have to keep the urine pH alkaline, usually greater than 7.0. We run IV fluids with sodium bicarbonate to alkalize the urine.
And you're checking it constantly.
We literally check the pee with a dipstick every single time they void. If it's acidic, we don't give the drug. It's that simple.
There was a specific warning in the monograph about neonates.
Yes, this is so important. The formulation matters. Some methotrexate vials contain benzyl alcohol as a preservative. In neonates, their immature livers can't process this. It causes gasping syndrome, fatal respiratory distress, acidosis, and death.
So you always check.
Always check for preservative-free formulations for infants and for any intrathecal use.
Okay, moving to prednisone, the corticosteroid.
The love-hate drug of pediatrics.
Oh, you say that.
Because it's so effective, but the side effects can be brutal. We use it for leukemia induction. Lymphoblasts are actually very sensitive to steroids. It just melts them, asthma, nephrotic syndrome, all sorts of things.
And the mechanism.
It suppresses inflammation and the immune response. It's also lympholytic. It actually breaks down lymphocytes.
But the side effects in children are really distinct.
They are. First is growth suppression. Long-term use can literally stunt a child height. Second is mood changes. We call it roid rage. A normally sweet child can become aggressive, irritable, or severely depressed.
You have to warn the parents.
You have to warn the parents. This is the drug, not your child being naughty. Third is the Cushingoid appearance. The moon face, the round cheeks, the buffalo hump, the weight gain. For an adolescent focused on body image, this is just devastating.
And the safety rule for stopping. This is a big one.
Taper. You can never stop steroids abruptly after long-term use. The drug suppresses the child's own adrenal glands. If you pull the drug, the adrenals are asleep and can't make cortisol.
And the child goes into
Adrenal crisis, which is shock. You have to taper slowly to wake the adrenals back up.
Any tips for administration? Because it tastes terrible.
It tastes horrific. Incredibly bitter. You have to crush it and mix it with something strong, chocolate syrup, strong jam, but mix it in a small amount, like 1 spoonful. If you mix it in a whole bowl of pudding and they only eat half, you have no idea how much drug they actually got.
Okay, we're in the home stretch. This is section D, cross-linking and synthesis. Let's connect these dots.
Let's link leukemia and methotrexate. We said methotrexate attacks rapidly dividing cells. Well, the lining of the mouth divides rapidly. This causes mucositis, severe ulcers from the lips all the way to the anus.
And this links back to nutrition.
Of course. If a kid's mouth feels like raw meat, they won't eat. So the nursing intervention is bland, soft foods, no orange juice because the acid burns, no potato chips because the sharp edges cut.
And you use things like magic mouthwash.
We use magic mouthwash, which is usually a combo of lidocaine, Maalox, and diphenhydramine to numb the mouth so they can eat and get some nutrition in.
Okay, let's link leukemia and prednisone.
This is the double whammy for bones. The leukemia itself causes bone infiltration and pain. Then you add prednisone, which causes osteoporosis or bone weakening.
So you put them together.
And you have a child with incredibly fragile bones. So the safety point is, handle them gently, no roughhousing. They are at a very high risk for pathological fractures.
And let's synthesize pain management across the board because it can be confusing.
It is, so let's simplify. For sickle cell, opioids are the standard of care. Do not fear addiction. Treat the crisis.
Okay.
For hemophilia, Tylenol is safe. NSAIDs like ibuprofen or aspirin are dangerous because of the bleeding risk.
And for leukemia?
For leukemia, you can use Tylenol for pain, but you have to be careful. A Tylenol masks fever. And in a neutropenic kid, fever is the only warning sign you might get of a deadly sepsis.
So you might hold it.
We often hold Tylenol until we have thoroughly assessed for infection. We need to see that fever if it's there.
That is the kind of nuance that really separates a novice from an expert.
It's all about knowing the why behind the rule.
So we've built the map. We've covered the diseases, the meds, the connections. What does this all mean for the listener standing at the nurse's station?
It means that when you review a chart, you aren't just checking boxes. You are looking for the safety patterns. Is the airway safe? Is the immune system working? What's the ANC? Is the blood clotting? What are the platelets and factors? And critically, is this child able to be a child?
That brings us to our final thought. The resilience of the pediatric patient versus the fragility of their physiology.
It's the great paradox of pediatrics. Kids bounce back emotionally and physically from things that would absolutely crush an adult, but their physiology has so much less reserve, they crash faster.
So what's the provocative thought you want to leave everyone with?
The thought I want to leave you with is this. We spend so much time treating the numbers, getting the HgbA up, getting the ANC up, but the patient, the person, is trying to grow up. Every time you intervene, whether it's a hospital admission, a steroid course that changes their face, or a restriction on sports, you are altering the architecture of their childhood.
So the challenge is?
The challenge is, how do we keep them safe? That's our 80-20 clinical focus? Well, disrupting their development as little as humanly possible. So when you review a chart, ask, is this safe? And then immediately ask, how does this affect their next birthday party? Can they go?
Wow.
If you can answer both of those questions, you're doing the job right.
That is powerful. Can they go to the party? That's the real goal. Thank you for joining us on this deep dive into pediatric heme-onc. It's a beast of a topic, but hopefully the 80-20 map makes it a little more navigable.
Keep looking for the patterns. Safety first, development always.
See you on the next dive.